Hello, my name is Michael Feldman, and I'm the medical director of the Evans Haynes Burn Center, which is part of the Virginia Commonwealth University in Richmond, Virginia. I'm here to discuss burn nutrition as part of the Panamerican burn course. Thank you very much for your attention, and we look forward to educating you more on burn nutrition. Our learning points include that burn injury leads to a hypermetabolic response. Burn wound management is tied to nutrition. We'll learn that adjuncts to burn nutrition may reduce hypermetabolic effects. We'll review common burn nutrition formulas, as well as the differences between gastric and post-pyloric nutrition, and learn a burn-centric approach to MPO status. Burn nutrition is extremely important because traumatic injury creates a hypermetabolic demand. This is particularly robust in burn patients who need the most nutritional support of any group, including sepsis and trauma. Burn patients register increases in cortisol, epinephrine, and glucagon. This is in addition to a reduction in protein synthesis and antagonization of growth hormone. There are some children who won't grow for a year or so after a large burn. Burn patients have been known to increase their energy requirements by as much as 100%, and this can last for months to even a year. Burn nutrition and surgical intervention are intertwined. Early surgical intervention may reduce the metabolic demand, but not eliminate it entirely. Early surgical intervention and nutritional support can lead to less immune dysfunction, less lean body mass loss, a reduction in impaired wound healing, infections, and mortality. I want to next discuss two medications that have been shown to ameliorate the hypermetabolic response. These include oxandrolone and propranolol. Oxandrolone is an anabolic steroid which was described by Dr. Herndon in his burn group in Texas. Oxandrolone was used as a double-blinded placebo-controlled trial with twice-daily administration versus placebo. They did this over 3 years in children with large burns. The oxandrolone was dosed at 0.1 milligrams per kilogram twice a day from discharge until 1 year post-discharge. They looked at outcomes measures at 6, 9, and 12 months. They measured multiple labs. They measured resting energy expenditure with portable metabolic charts and completed questionnaires essentially looking for complications or side effects of the oxandrolone. The groups were very similar with no statistically significant differences between the two. The oxandrolone arm did show improvements. They had less lean body mass loss and better bone mineral content. There were no real side effects to the oxandrolone, no excessive hair growth or precocious pubertal development. There were 2 female patients who had developed clitoromegaly, although it's not clear if this was due to perineal burns or not. They did stop the oxandrolone at that time. There was no noted change in hepatic function. The second medication is propranolol, a well-known beta blocker. The hypothesis was that this may reverse the catabolism of severe burns. This is once again by Dr. Herndon and his burn group in Texas and was published in the New England Journal of Medicine in 2001. This study hypothesized that beta blockade may reduce the myocardial work, lipolysis, and negative nitrogen balance of burns without negatively affecting cardiac or metabolic function. It may, in effect, allow the body to rest, much like this frog on his lily pad. The propranolol study was set up with 25 children, all with large burns, randomized to either receive PO propranolol or control. The dose was adjusted to decrease the resting heart rate by 20% from baseline. The groups were very similar, with no statistically significant differences. They were successful at dosing the propranolol without hypotension. They were able to show that in the propranolol group there was a significant decrease in loss of lean body mass There were no adverse effects. although they did have to temporarily hold the propranolol in 3 of 13 children. They also were able to show an improvement in net muscle protein balance and increase in lean body mass. Burn nutrition is important for so many factors. Once you've ameliorated the hypermetabolic demand, patients still need nutritional support, as this can mitigate intestinal mucosal damage and bacterial translocation. We believe that burn nutrition is ideally started within the first 24 hours, especially in large burns. Unfortunately, burns can lead to poor gastric motility, and the presence of an ileus needs to be taken into account. There are many benefits to feeding the gut. TPN has been shown to cause liver dysfunction, infections, decreased immune response, and increased mortality. Feeding the gut may also reduce the risk of curling ulcers and may reduce time in the intensive care unit. Calculating burn nutrition is no easy feat. The Curare formula, first described in 1972, tends to overestimate. The Harris-Benedict, on the other hand, is good at estimating basal energy requirement. There are multiple other formulas, such as the Toronto, Davies, Ireton-Jones, and pediatric formulas like Galveston or Curare Jr. Here I highlight the Harris-Benedict and Curare formulas once again. The Harris-Benedict separates patients based on gender, weight in kilograms, height in centimeters, and age. The Curare also separates by age, weight, and percent body surface area. For burn nutrition, carbs are king. High-carb diets are linked with less muscle loss in burn patients. Carbs are the favored energy source, but protein is a must to help with wound healing and immune function and to limit loss of lean body mass. Glutamine has been directly linked to gut immune function and the function of lymphocytes and enterocytes. Glutamine can be rapidly exhausted after a large burn, and supplementation may reduce mortality and length of stay. When we are feeding the gut, there's the discussion of should it be gastric or post-pyloric. While we prefer intestinal feeds, these can sometimes be challenging. In patients with an ileus, one would want to avoid gastric access. However, gastric tube feeds are a larger diameter and quicker to place, as well as give you the ability to bolus feed. Post-pyloric access is smaller and thereby more comfortable and tolerated by the patient, but can be more difficult to get into place. If they have post-pyloric feeds in our institution, they can be fed even during their surgical interventions. And this is quite helpful in large burns where they're going back and forth to the operating room multiple times a week. Here are the MPO guidelines for our institution. Notice that we try and mitigate MPO as much as possible. We'll allow them to have clear of liquids up to 2 hours before surgery, breast milk 3 hours before, and 6 hours before they can have non-clear liquid solid food or infant formula. For those with gastric tube feeds on positive pressure ventilation, they can be fed up until they go to the operating room. If they have gastric feeds and are not on positive pressure ventilation, the tube feeds are held at the standard time. For patients with jejunal feeds, they can be fed before, during, and after surgery without having to hold it at all, regardless of their ventilatory status. Burn nutrition can be difficult to monitor. We will check albumin, prealbumin, and transferrin. We'll also monitor their body weight, either weekly or daily, and calculate their nitrogen balance. This is done by collecting your urine output for 24 hours, which requires the urine to be kept on ice and sent to the lab. A positive balance is associated with growth and healing, while a negative nitrogen balance can be associated with muscle wasting and immune dysfunction. Finally, burn nutrition that's based on formula calculations can be flawed at times. One can use indirect calorimetry as an adjunct to give a more accurate snapshot of the patient's energy expenditure at any particular time. Indirect calorimetry measures the volume of expired gas along with inhaled and exhaled concentrations of oxygen and carbon dioxide and allows for calculation of oxygen consumption, carbon dioxide production, and thereby the metabolic rate. This could help reduce over or underfeeding, but requires that candidates be ventilated with no recent surgery or dialysis, as this can skew the results and be free of stimulation for upwards of 45 minutes or so. The patient needs to be left alone. One cannot even talk to them or enter their room, as this may also skew the results, so it's quite sensitive. While this can be a helpful adjunct to ventilated adult patients, we're working on expanding our use for it in patients who aren't intubated in our pediatric population. We hope that you found this discussion of burn nutrition helpful and appreciate you attending the Pan American Burn course.